Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a podcast show that delivers cutting-edge ideas for the professionals specializing in pediatric dentistry.
Thank you for tuning into Pedo Teeth Talk, where we bring you the contemporary issues important to you and your practice. Brought to you by the American Academy of Pediatric Dentistry. Thank you to our Pedo Teeth Talk sponsor, Hugh Freedy, for helping us bring you great content. We couldn't do this without them. Visit them at www.hughfreedy.com. That's h-u-friedy.com. We're here today with Dr. Bill Wagner to talk about an extremely important topic in clinical practice, zirconia crowns and how we got there to them. First, let me tell you a little bit about Bill. Dr. Wagner has been in full-time practice in pediatric dentistry in Las Vegas, Nevada since 1996. He graduated from the West Virginia University College of Dentistry in 1980 and completed his Master of Science degree in pediatric dentistry at the University of Iowa in 1982. From 1982 to 1986, Dr. Wagner held a full-time academic appointment at the University of Oklahoma College of Dentistry. From 86 to 95, he was Associate Professor of Pediatric Dentistry and Director of the Children's Dental Clinic at Ohio State University College of Dentistry. Bill has numerous research publications and peer-reviewed dental journals and the author of several chapters in pediatric dental textbooks. He's a diplomate of the American Board of Pediatric Dentistry and a fellow of the American Academy of Pediatric Dentistry and the American College of Dentists. Dr. Wagner is a frequent speaker on the subject of dentistry for children. He has been a featured seminar speaker at the American Dental Association and has given dental presentations internationally in areas such as Russia, Portugal, China, Korea, Mexico, Thailand, Argentina, and over 30 states in the U.S. He currently owns and operates 4 pediatric dental offices in Las Vegas with over 35 employees, including 4 other pediatric dentists. He also is a consultant and occasional lecturer for New Smile Crowns, one of the makers of primary zirconia crowns. Dr. Wagner has been married over 40 years to his wife, Linda Ann, a marriage and family therapist. They have 4 grown children. In his spare time, he's devoted to family activities, reading, and travel. And Bill, I'm so glad you agreed to talk to us today because this topic of zirconia crowns, of aesthetics in the primary dentition is getting bigger all the time. Thank you so much for being here.
Joel, thank you for having me. It's a pleasure to talk with you, be able to talk some about zirconia crowns and how we've got to this place. And thankfully, we have gotten to a place where we have another alternative that's more aesthetic than probably anything else we've had, especially when you consider the durability. So anyway, it's my pleasure to be here, and I look forward to our conversation.
Well, thank you, Bill, so much. I want to start off by, you and I trained in the same place around the same time. And back then, we were doing stainless steel crowns and anterior teeth as well on occasion. But, mainly there we were doing window cutouts and sometimes strip crowns. And now we've really moved pretty far forward toward these aesthetically desirable crowns. I just want to ask you right away, are zirconia crowns going to replace crowns in the primary dentition pretty soon?
I seriously doubt that they will. I think a stainless steel crown is a wonderful restoration, and I think from a cost and insurance standpoint, that's probably going to be one of the deterrents for a complete replacement. One of the things I want to say right off the bat is I think zirconia crowns are really a wonderful add-on to our armamentarium of what we do in fixing kids' teeth. But I want to say this. I feel like that zirconia crowns are one more tool in our pedo toolbox. And so to think that they're going to eliminate strip crowns or pre-veneered crowns or stainless steel crowns, I just don't think that's going to happen. I feel like that we have a number of things right now, like SDF and smart restorations. We got the Hall technique, and now zirconia crowns. And some people might be concerned that I would group all those things together because they're actually quite different. However, the point I want to make about it is that for the people who kind of feel like, well, SDF is the silver bullet, or feel like the Hall crown is like, I don't have to prep teeth anymore, this is wonderful. If they're thinking that that's going to replace most traditional sorts of restorative dentistry, my personal opinion is I would disagree. And for the same standpoint, I think zirconia crowns gives us one more tool in a toolbox. And as a clinician, the more opportunities that we have to look at a number of options on restoring any child's tooth or teeth, I think the better a clinician we become.
Yeah, I really appreciate that comment and that perspective, Bill, because when new products come out or new ideas and techniques come out, you often hear people say, well, this is going to, and I posed the question in that way intentionally, and you gave me the answer that I expected you as the expert to say, that nothing replaces everything, but it adds to the options. So along that vein, you mentioned cost. So, every parent wants, if they have a choice between stainless steel on a molar, and now we have availability of these zirconia crowns, certainly an anterior, most parents are going to say, well, I'll take the aesthetically desirable one. So if they were the same price, and they're not, I understand. So is cost the really big factor why they're not going to replace a lot of stainless steel crowns, maybe for molars particularly?
I don't think it's cost as much as it is insurance. And, I am a clinician that's been in practice for over 22 years after I left academics. And in the community in which I practice, which is Las Vegas, if you are not taking assignment by insurance, if you're not taking Medicaid, you're not very busy, because that's the nature of our community. So at this point, we have some insurances that will pay for instance, zirconia crowns on anterior teeth, but don't on posterior teeth. And again, in the population that we serve, even though parents may want that added aesthetic, if they're looking at paying a $35 copay for a stainless steel crown, or paying maybe $275 or more for that white crown that wasn't covered, most parents are going to pick the $25 or $30 copay on the stainless steel crown.
Right.
But if you completely eliminate the cost factor, you still have the cooperation factor. And there's no question that it takes more chair time to fit a zirconia crown. The cementation, and we can get into that a little bit later.
Yes, I'd like to.
More technique sensitive. And so when you've got a kid who's not a very happy camper, yeah, you can do a Hall crown if you have to, in 3 or 4 minutes, or do just a little bit of prepping and get it on there. But that isn't going to exist for zirconia crowns.
Yeah, that option isn't there. You need you need isolation, cooperation, and time. You need all those things. Kind of like a resin composite. It's like it's not exactly that, but as far as the cementation. So, speaking of that, in terms of let's focus on the anterior region. And I introduced this by talking about the way we used to do things, you and I. And
sure,
are you seeing people still using a lot of like window cutouts with composites? Is that still prevalent? I just want to cover these really quickly.
Well, at least in my neck of the woods in Las Vegas, and we do see a number of patients that have moved from California, we rarely see the open-faced or the cutout crowns anymore. I can't remember the last time.
Yeah, I haven't seen many. What about pre-veneered? You mentioned those.
I think pre-veneered are still fairly popular. I still do some, not nearly as many as I did prior to zirconia crowns, but I think that they still have a pretty good market, at least the anteriors. Posterior pre-veneered crowns have virtually no market.
I see. So they're either going to do the stainless steel or the zirconia there, pretty much.
I believe so, yeah.
Yeah, I think that the marketplace reflects that. Speaking of cooperation, I know that a lot of large amounts of restorative dentistry at one time obviously is being done under either oral conscious sedation or general anesthesia in particular. So this issue of cooperation goes away. So would you say, in your experience, in your preference, given the challenges of cooperation, that if the child's asleep or deeply sedated, then the difficulties, the challenges, and I want to ask you what those are specifically in the preparation, would be minimized? Is that a fair way of saying it? And then it's less of an issue?
I would say absolutely. In fact, I anticipated one of the questions you might ask me would be, what recommendations might I have for somebody if they hadn't done any zirconia crowns? And one of the things I was going to say is, by all means, choose a good sedation patient or a GA case where you have time and complete cooperation, those are the cases to kind of start understanding how these fit and how your preps work. But if you're working on a non-sedated 4-year-old trying to do 2 or 3 or 4 of these anterior crowns, bless your heart, it will probably be a bit of a challenge, and it may cause you to say, why in the world would I want to do this? Now, once you've done 50 or 60 of them, you'll realize that the prep is not that tough, doesn't take that much longer, but you've got to get some under your belt to get to that point.
So without going into too much detail, for those in the audience who have not placed zirconia crowns or have not placed many, you're an expert. What is your technique? Can you tell us in a couple minutes the technique and what the challenges are and what the differences are?
Sure. First of all, we'll talk about anterior. If any of the listeners have ever done pre-veneered crowns, then the prep is almost exactly the same as a pre-veneered crown. If you're used to doing strip crowns, you just have to take everything. You have to reduce more circumferentially by probably at least twice as much. So you're going to have about 1.5 millimeters mesial distal reduction. You're going to have about 1 millimeter on the facial, 0.5 millimeter or so on the lingual, about 1.5 millimeters of incisal reduction, and you want to finish it to a feather edge. So it's a lot of circumferential reduction, and you've got to eliminate any bulges because these crowns need to fit passively. If you try a friction, not a friction grip, but if you try a friction related fit to your crown, you're liable to break it. Mm-hmm. So that's for the anterior. For the posterior, it's a circumferential prep too, and especially on first primary molars, you've really got to work on getting rid of that mesial buccal bulge. You've got about 1.5 millimeters of reduction mesial distally, about 1.5 millimeters off the occlusal. And quite frankly, from the occlusal, you don't have to do a whole lot more reduction than if you were doing a stainless steel crown.
Right.
When we used to have the pre-veneered posterior crowns, you had to reduce like 3 to 4 millimeters, and almost always we're going to get into the pulp. There's no reason that should be an issue with zirconia crowns.
So speaking of getting into the pulp, I'm glad you mentioned that. You hear that some cases people do more zirconia crowns, they do more pulpotomies, not because the decay led them there, but because of the prep. Is that a valid statement or not? Or is that a true situation?
Well, it's a true situation that you hear people say that. Whether or not it's a true situation that it's required, I would take issue with. None of the manufacturers of the zirconia crowns recommend any kind of routine pulpal therapy like prophylactically.
Right.
They would all say caries dictates the need for pulpal therapy, not your preparation. Now, is it possible that you can have kind of an aberrant pulpal horn when you're prepping one of these teeth and get it exposed because there's a bit more of reduction? Absolutely. But that can happen with a stainless steel crown or
anytime.
Even doing a DO sometimes. So, no, I don't think the need for pulp treatments just because you're doing more preparation is a requirement. And I say that, again, this is anecdotal, but I've done thousands of pre-veneered crowns in the anterior. And it's, as I mentioned, the preps are almost exactly the same as when you're doing a zirconia crown. And we did not see any kind of, increase in failed pulps on our pre-veneered crown. So I can't understand why that might be a concern with the zirconia.
Well, I'm glad you covered that. And one quick question is, do you, therefore, to avoid that, is it helpful to you to prep the zirconia crown, for the zirconia crown, seed it so that you can verify that it's going to work, and then remove the decay, as opposed to cutting the prep and removing the decay at the same time? Does that make sense? Is that a valuable thing to do?
I think it's 6 of one, half dozen of the other. I know some people who always remove the decay first so they can determine if they've got to do a pulp, and then they're actually working on the pulp treatment while they're doing the rest of the prep. And I have other people who routinely do their prep and then they see if they're going to need to do pulp. So I don't think there's any advantage one way or the other. It's kind of what you're used to doing.
Okay. We will now pause for a word from our sponsor.
Hugh Freedy is the global leader in dental instrument manufacturing and infection prevention solutions that keep you performing at your best. For more information on Hugh Freedy products, visit hughfreedy.com/AAPD crowns. That's hugh-freedy.com/AAPD crowns. And enter the promo code 2682 if placing an order for pedo crowns.
We are back with Dr. Bill Wagner. We're talking about zirconia crowns and how they've just really come on board strongly. And Bill, we were just talking about prepping the crowns, and we have very limited time. There's so much I want to ask you, but I want our listeners to really hear how you, the expert, do this. So let's talk about cementation. So you've got the crown fit, the decay's removed, the crown fits, and now you want to cement it. So what are you going to cement it with, and what's your technique?
When you go to adult literature with zirconia crowns, and zirconia crowns have been used in adult dentistry for over 20 years, it appears that GPs and prosthodontists, their cement of choice is a resin-modified glass ionomer, more so than just a regular glass ionomer. Some will use a resin cement, but those tend to be pretty technique sensitive. And so most of the time using a resin-modified glass ionomer or a bioactive cement like Ceramir or BioSim from New Smile, those would be the ones that would be mostly of choice. Now, I want to quickly say that I love Keytac cement, glass ionomer. I've used it for years and years and years.
Traditional glass ionomer, not resin-modified, the regular Keytac.
Right, it's traditional.
Like that. Yes,
I think for stainless steel crowns, for pre-veneered crowns, it is awesome. You can abuse it, and it just sticks. So I love it. But in the studies that they've looked at for retention to zirconia, glass ionomers are actually about 50 to 100% less bond strength to the zirconia as the resin-modified glass ionomers or the bioactive or resin cements.
I see. So I want to talk about before cementation. One thing I forgot to ask you is I believe at least one of the manufacturers, I believe New Smile, has a Tryon crown, and I don't know if the others do. Is there an advantage to having a Tryon crown in the kit?
Thanks for asking that question because it's a very common question. Studies have shown that when zirconia is contaminated by blood or saliva, the phosphate groups in those substances will attach to the zirconia and then compete with the cements. So if you're looking for primarily a chemical adhesion of your cement to the zirconia, then it's very important that you not have contaminated zirconia so that you get a maximum chemical retention or adhesion to the zirconia. Now, the reason that New Smile has them and the other ones don't is that the New Smile crowns are die formed. The other ones are milled on a machine, and the ones that are milled on a machine can actually have some internal grooves cut on the insides of the crown. So they actually have some internal retention as part of the crown. New Smiles have to be pulled off of a die, so they cannot have an undercut or they'd never come off the die.
So however, presumably the contamination might be less of an issue for the others, so therefore the Tryon is less important for them.
Right, because I believe that the other ones are relying probably more on the mechanical retention of the cement inside of the crowns, where the New Smile, even though they have a very rough intaglio surface on the interior of the crowns, they don't have undercuts per se. So they are looking for maximum chemical adhesion of the cement, where my feeling is the other ones are looking, they will take the chemical adhesion, but they're good with the mechanical.
Physical retention, mechanical, which is what you have with the stainless steel crown, but that has crimping and all the other things. The question, is there an easy way chairside to remove a contaminated surface? Should it be believed to be contaminated?
Well, water and alcohol and etching don't seem to do anything to that. However, if you've got a sandblaster, you can do that. And then Ivoclar makes something called IvoClean, which is what GPs and prosthodontists use to clean it out. Because obviously they don't have Tryon crowns.
Right. What they're doing, of course, is a whole set of things that I'm somewhat familiar with, where they blast them with sandblasting. They might even have a silane coating placed on, and then they use a resin cement. So they get a resin cement. And I think I was going to ask you, do we use resin cements for these zirconia crowns ever? Not resin modified, but actual resin cements?
You can. I don't know anybody who does. Like I said, they tend to be more technique sensitive. They're very great on micro leakage when they're done well. But I don't think a lot of pediatric dentists go to that extent. And I'm not sure we need to. Okay.
And in Las Vegas is a big city, so you talk to people in study clubs and things like that, and I the same. Are you seeing a steady increase in the use of aesthetically desirable crowns as opposed to other methods?
The answer I would say is yes. I don't have strong data on that, but I think the fact that all of these companies that make the crowns seem to be doing well indicates that there's definitely a demand there.
Yeah, I think there likely is. And the related question is, I saw that at least one company, and I've heard that several others have or have introduced a permanent molar zirconia crown. So, prefabricated in different sizes. Are you familiar with that, and do you think it's necessary?
To my knowledge, New Smile is the only one that has introduced the permanent one thus far. I wouldn't be surprised if somebody else does as well sometime, but New Smile right now. In my opinion, I think that it does provide an alternative to those molar crowns with severe MIH. I think there has been some question like, well, aren't you having to take too much tooth structure away? And isn't that going to later on maybe cause a problem for the dentist who wants to do a permanent crown? I guess I don't see that as a great big problem. We tend to do a reasonable amount of reduction when we're doing stainless steel crowns to get a nice one to fit with good margins on permanent teeth. So I don't know that that's a real valid argument. Could be, but I don't. Yeah, it's not one that I would make.
I was thinking for these, hypoplasia or hypocalcification cases, which we are presumably seeing more of, that perhaps that might be a good alternative.
Yes.
Yeah, those kinds of cases. So I wish we had a lot more time, but I really have time for just one more question, Bill, and that is, if you're talking to an audience or to an individual who's listening who's never done zirconia crowns and they're thinking, God, I really need to do this. This seems like something for a lot of my patients in these cases. Give us just a few solid pieces of advice to somebody who's starting out, what to avoid, what to look for, what not to do. Really would be helpful.
Okay. I mentioned one previously, and that is, I think, choosing it for a GA case or a sedation case. And if it's a sedation case, I would say not one where you're also fixing 8 other teeth, kind of keep it limited to the anterior. I think it's good to have, when you're doing them at first, having a good bit of tooth structure left because there's no crimping of these crowns. It's all a passive fit. It's all being held on by the cement. And to this point, I don't know if anybody knows how much tooth structure is enough tooth structure. So I think having at least half of the normal tooth structure available is a good way to start. Don't start with just a nubbin of a tooth and hope that the thing stays on.
Would you start with an anterior or a posterior or a molar?
I would start with an anterior, actually. But if I were going to do a posterior, a couple of things. Avoid areas of space loss because those can be really challenging, even with stainless steel crowns. I would say avoid a back-to-back case where you're doing the D and the E at the same time. If it's your first one, just either choose to do the D or do the E. And let's see. Yeah.
Well, those are really good piece of advice. Yeah.
I'm sorry. The last thing I would say is that you've got to give it a chance. As dentists, we kind of get used to doing something, and then when something new comes along, we may try it 2 or 3 or 4 times, and if it doesn't immediately If it's not easier, faster, better, then we just leave it on the shelf. And I think with these, you've got to understand there's a learning curve. Yes. And once you get to that learning curve and you start seeing some of these back on recall, Joel, the gingiva can look so healthy. They rarely stain, and if they do, it's very easy to clean stain off. They're very durable. It's extremely difficult to break one of these, except, and I want to say this, these crowns do not flex. So if you try and force them down over a too large of a prep, you will break it. Now, you could probably take a hammer and hit it, and it wouldn't break. But if you try and flex it, it's going to be in pieces.
Flexural strength is not there. Yeah, it's got great compressive. Thank you so much, Bill. You've given us a lot of pointers that people can take back to their office, and very, very useful. Thank you so much for being with us today.
Joel, it's my pleasure. It seems like the time went by really, really quickly, and we could have probably talked for at least another 25 minutes. So thank you so much for having me.
We'll do it again some other time on a related topic. There's so many things you and I could talk about. Thank you very much. And
absolutely.
Thank you to our audience. Thank you for tuning into Pedo Teeth Talk, where we bring you the contemporary issues important to you and your practice. Brought to you by the American Academy of Pediatric Dentistry. And we'll see you here next time very soon. Thank you very much.
Pedo Teeth Talk is brought to you by the American Academy of Pediatric Dentistry, the show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry. If you have any questions or comments, please email info@aapd.org. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org.